Let's go. So look, I am excited tonight to introduce Dr. Rudi Falovic, who recently passed the ANZCA primary exam last month. Now, for those who don't know, Dr. Falovic has a photographic memory, but despite all of that, he is one of the hardest working trainees that I know of. I taught him everything I know, but he has taken it to another level. And I'm excited today to learn of him in terms of structures and how to approach both the written as well as the Viva as well. Now, Dr. Falovic is still currently serving in the Australian Army, and the charity that he's supporting tonight is the Commando Welfare Trust that supports soldiers and families from the Australian Commando Regiments. Rudi, to you and to all those amazing soldiers and Australians and New Zealanders who have fallen, I thank you for your sacrifice and the sacrifices that you continue to make to allow us to live in this amazing free country. So thank you so much, Rudi. And I will pass it over to you.
Thanks so much for the introduction. That was, well, just lovely, Stan. Good day, everyone. I actually know a few of you already. We've crossed paths. I've just seen someone I went to med school with, which is fantastic. G'day, Nikki. So essentially my aim here, we'll go through some PowerPoint stuff and we'll go through some diagrams, we'll go through some structures, but essentially something which I was given feedback about from people within my study group and study groups externally to me was that they liked my approach to answering the most amount of questions with the shortest amount of structures. So the ability to cover the majority of content without having to create a unique SAQ for all of them. And I've attempted to do that and teach that to a few people, and they found it quite helpful. So I thought we'd do something similar tonight. And the things that I wanted to go through essentially would be some of those structures in relation to SAQs, some of the more annoying topics in relation to onset and offset of different pharmacological agents, and then a bit of fun, essentially, which will be a bit of a Q&A, and we'll just go through some rapid fire sort of base concepts that you need to know pretty well for your Viva. And it's good to just sort of start thinking about them now. So without further ado, we'll crack on. So this is, well, the 6 Ps. And essentially, this is something that I've, has been there from my military career from 2006. But essentially, it's pretty self-explanatory. Prior preparation prevents piss poor performance. And you've done a lot of that prior preparation, I'm assuming already, in relation to your content. But what you will soon learn as you move into the phase of actually preparing for the written and the Viva is that the knowledge is only about 60% of what you need, and 40% is actually the delivery, the structure, the way you present information, which was quite a shock after I'm sure many of you have spent hours and hours and hours writing SAQs. It just can't be replicated in 8 minutes, which you realize when you do your first paper. So some of the things we're going to go through, structure, layout, pages and the limits to pages, depending on how fast and how accurately you write. As Stan can attest to, my writing is very, 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 very poor. I think I've got a text thread about 80 pages long where he's just sent screenshots trying to decipher a word, for each sentence. So that's something I had to put a lot of effort into so that people could actually understand what I was trying to get across. Another point is effect before concept, which is something I learned quite late in the piece, and I wish I'd thought of early, and that is that when you're writing an SAQ, you've learned all of this physiology and all of this pharmacology and all of these pathways, and you want to explain them, especially when you're not expecting the question. But if you can just front load the answer with the actual answer to the question and then describe why all those things are important, you will get higher score, and you will finish your question a lot quicker, and it will make a lot more sense and be easier to read. And then get to the point earlier, which is very similar to that. In that same vein, the only way you're going to get good at that is by getting people to mark your SAQs, all right? And not just one person. Like, obviously Stan's great, he's marked, you know, heaps of my SAQs, but it's good to get a variety of people to have a look at them and give you some genuine feedback to look at what you can improve on. And then we'll have a look at some of the Viva structures and the difference just between, you know, for a given topic, how you would change your SAQ approach to your Viva approach. Okay, so this is just essentially, yeah, the importance of the fact that it's only a little bit about the knowledge, and you actually need to know what's important and what you shouldn't be putting in. Otherwise, when you look at something like, for instance, ketamine nightmares, which a lot of you have probably looked at, and there's nothing wrong with that, you'll, especially for instance, a compare and contrast question about two different agents, if you try to write down all of those things, you will get maybe through physiochemical, maybe half the PK, and you won't get pharmacodynamics. So it's important to actually elucidate what's the key knowledge, pick some points, and then try and get them down. Okay, so these are some of the things I want to go through with you guys today. So from a respiratory perspective, just compliance, work of breathing, oxygen and CO2. So the first thing we're going to do is just go through an SAQ structure for compliance, some mnemonics to help you get all the points down, and then how that would differ if you were trying to deliver that as a Viva. So does anyone want to just sing out a definition for compliance?
A change in volume over a change in pressure.
Great. So unit change in volume per unit change in pressure. And if you want to throw some units on there, so mils per centimetre of water, that's also good. All right, great. So now, what types of compliance do you know? Anyone else? Otherwise, I'll just start stabbing people.
You got static and dynamic and specific compliance.
Right, okay. And what is static compliance?
So I think of static compliance is compliance when there is no gas flow, and then dynamic compliance, more of compliance when there is gas flowing, although when it's measured, it's measured when the airflow has actually stopped.
Yeah, so there's an important distinction there. So static compliance, as you've rightfully stated, is where there is an absence of flow. But the other really important aspect to sort of differentiate the two is that equilibrium has occurred. So all of the time-dependent factors have been able to equilibrate, and therefore that's why your static is always greater than dynamic. Dynamic is also when there is absence of flow. Yes, it might be at the end, inspiration or expiration, but there is no flow. So that's where people trip themselves up often, I've found. The difference is that equilibrium has not occurred, right? So all those time-dependent factors are why your dynamic compliance will always be less than your static. Does that make sense? Cool. All right, and then specific. This one I want to just quickly tell you what specific compliance is.
So it's compliance divided by FRC, and so it's standardized over different ages of population, for example.
Okay. What type of compliance are we talking about? When you say it's compliance divided by FRC, which one? Dynamic or?
Static compliance.
Good. All right. All right, so we've gone through some of this already. Now, the diagram for this is something that trips a lot of people up. So what I thought I might do is just draw out my version and see how it compares to yours. And if you like it, you can essentially plagiarize the hell out of it, because I plagiarized it from Stan, so it's all fine. So just give me one moment. Okay. Hopefully everyone will be able to see this. All right, so when we're drawing compliance, and if you want to cover everything off as quickly as you can, obviously you're going to draw standard X and Y, right? So your units for your Y and X axis are up to you. I think the best way to draw this and to get the most amount of points is to actually draw both static and dynamic at the same time, and one within the other. So the way in which I would do this is I would have, you know, say let's call this pulmonary pressure, right? And this can be in centimeters of water. And then on my y-axis, I'm going to have volume, okay? And this can be lung volumes in litres, it can be mils. I think, you know, if you want to do 30 mils per kilo for your residual volume, sorry, for your FRC, 15 for residual, 7 for your total volume, that's all fine as well. So we'll just put some numbers on here. So we're going to have residual volume, functional residual capacity, all right? Total volume and total lung capacity. And you can add the volumes later, okay? So here I'm going to have minus 10, 0, 10, 20, and 30, all right? So the way in which I would draw this is I'm going to start from residual volume because I'm drawing total respiratory compliance, and I'm going to start with static, okay? Please excuse the drawing if it's a bit dodgy. Something like this. All right, so this is going to be my static curve, all right? And then within that, I'm going to have my FRC, sorry, my dynamic compliance curve, which is going to obviously come from my FRC at about, let's say, 5 centimeters water to 8, like so, all right? Gradient is obviously equal to compliance. You can quickly label inspiration if you'd like, expiration, and then this here is hysteresis, okay? The observation that the distending pressure required for inspiration versus expiration is different, which is known to occur with elastic bodies. And again, if you want to label, you know, that this is static and this is dynamic, that's fine also. Has anyone seen something like that? Or has anyone not seen something like that before? It's okay, all right. So what I would then do, okay. Oh, sorry, one second. If I'm answering this question, I've now defined compliance as an SAQ. I've drawn this graph. I've demonstrated the difference between static and dynamic. And I've given an example of where hysteresis is on the curve, which is important. Now what I want to do is talk about determinants, all right? So you can split your determinants up if you'd like to. There can be the determinants of lung compliance versus chest wall. Now, a mnemonic that I used and my study group ended up using, which I made up, separated essentially lung compliance and chest wall compliance. And the reason I came up with this mnemonic is because what I wanted to do was get everything out that I could in 9 minutes and actually answer every part of compliance. So the mnemonic is just SVT, and it's on the slides, it'll show you, but it's essentially SVT. So if we do lung compliance determinants. So SVT, like supraventricular tachycardia, and then just great positive pressure ventilation, okay? And these are all the factors that affect lung compliance in isolation. So this is your size, your volume, tension, which is going to be surface tension, obviously, and then you can, you know, write your law of Laplace there, gravity, position, and pathology, and then volume of blood. Okay, and then I would essentially just go through these and add a few points, you know. So for instance, from a pathological perspective, if you have a restrictive pathology, you know, it's going to decrease compliance. If you have an emphysema, for instance, it's going to increase non-compliance. Any questions on that, or how you would just go about quickly fleshing out, you know, a couple of words for each one of these?
No, but I really like that. It's a good mnemonic.
Yeah. Yeah.
Can you flash it out a bit?
Sorry?
Could you go through some of them and expand them, just a couple of them?
Yeah, of course. All right. So when you're talking about size, you're in the context of this mnemonic, I'm talking about absolute. So if you were to quickly write something down, you'd say an increase in absolute size increases lung compliance. All right. So for example, you know, like a rodent versus me, I'm going to have better compliance, a neonate versus an adult. So a short versus a tall. These are some of the absolute changes that we know make a difference to compliance. So if you just put a couple of those examples in there, does that make sense? From a volume perspective, this would be where I would be talking about the fact that your lung compliance is greatest at FRC. All right. And if I had time, I could quickly do this little diagram, and I'm sure you've all seen this one before, where you sort of have your deficits here and this here, you know, and you say that essentially your functional residual capacity is greatest at that volume, which is your FRC. Tension, you know, you just quickly sort of quote, you know, the law of Laplace, and you just talk about the fact that it's a factor and obviously improves your compliance by reducing surface tension. Gravitational, we just talk about the fact that you would have greater compliance in the dependent airways versus apical or non-dependent. And that's sort of reflected on this curve as well. And again, some of these points are somewhat repetitive, but this is so that you're actually addressing every single point. This was the quickest way for me to get it out. And then position and posture, it's getting a bit messy, but the slides are cleaner than this. This is where you would say, you know, erect, greater than supine, you know. But if you wanted to, you know, get a few extra points, you'd say erect greater than sitting, greater than prone, greater than supine, that sort of thing. Does that make sense? Yeah, I'm going to take no questions as yes, it makes sense. Cool. All right, and then we move on to chest wall. Oh, sorry, was there a question? No? Okay. So
actually, Rudi, I'll just ask one quick question. With your volume, how you had lung compliance as LC, would that suffice in the exam?
So only if I abbreviated it first. So when I was writing it out, I would do that.
Yeah, okay.
Yeah, so I would never use an abbreviation unless I'd already established it.
Mm-hmm. Cool.
Yeah. And then chest wall, I just sort of thought of this as, you know, outside to in, you know, skin, subcutaneous tissue, ribs, cartilage, spine, and then diaphragm, and then other is the way I did it. But one of my group members was planning their wedding, so we turned the acronym into DRESS, okay, which is diaphragm. So DRESS, which is diaphragm, ribs, external or other, spine, sternum. Oh, sorry, spine and skin. Let me just make that cleaner for you. Sorry. Okay, now if you quickly wanted to talk about some of the things, I think there's some really good points you can add on here, and a lot of people don't do them. So when I talk about diaphragm, for instance, you talk about obstetric patients, obese patients, pneumoperitoneum. You talk about ribs, you're going to talk about fractures, ossification of cartilages. You're talking about external things. This can be, again, these other populations, such as your obesity, etc., but it also could be like pneumothorax or something like that. When you're talking about your spine, this is where I throw things in like kyphoscoliosis, endotheliopathy such as ankylosing spondylitis. And then skin, I think circumferential burns is something you hear a lot about, but another one that's good is sort of systemic sclerosis or scleroderma. Okay. How does that sound?
Sounds awesome, Rudi.
Cool. All right. So then if you've got a bit of time at the end, and to be honest with you, I don't know if you had a look at that, like when you look at the way I drew that out, you don't need to really add too many points under each one of those to illustrate that you understand what you're talking about. And it doesn't actually take that long as long as you practice your diagrams. Then when it comes to...
sorry, Rudi, what was your SVT? What was the GPPV again?
Oh, great positive pressure ventilation. That's just how I remembered it. Like, that's just how I would remember it. And then when we'd have our group sessions, I'd make everyone repeat it a few times. But yeah, that's sort of how you would go about identifying all the effects or the things affecting lung and thoracic cage compliance. Then for extra money or potentially 5 out of 5, you want to start then discussing hysteresis or the time dependence of pulmonary elastic behaviour. Okay, so time dependence of pulmonary elastic behaviour was just sort of that end portion of this SAQ. So did anyone want to have a crack at describing exactly the factors that affect the determinants that go into this time dependence that we talk about and hysteresis?
Is it stuff like stress relaxation, change in surfactant activity? I think there's 2 or 3 other things that I can't think off the top of my head.
Yeah, I think I might have spoken to you about this, Pat. So you are right. And the best way to look at it is there's factors that affect static firstly, and then those that affect dynamic. And essentially, without going back to the screen share, the factors that affect your static, the static are your surfactant activity and recruitment of alveoli. And to sort of expand on that, the surfactant activity is just the fact that it changes. So we know that the DPPC is empiphatic. So essentially it's going to align at that border. And as your alveoli become smaller, they will then increase their forces of, they increase their ability to repel one another and therefore decrease surface tension. And as they get further apart, they have less activity, right? So that's one of the things that affects the static component. And then the other one would be recruitment of alveoli. And then when you subclassify into dynamic, it's going to be both those, plus your stress relaxation and your redistribution of gas or your pendulum. So they're the 4 factors affecting the time dependence. Any questions on that at all?
Yes, Rudi, I was going to ask, what would you would list those, and what would you write to explain your point?
Well, to be honest with you, if you're doing an SAQ and it's about lung compliance or it's about total respiratory compliance, this is going to be, minute 8. This is going to be like 8.5 minutes in, maybe 9 minutes in. So I don't think I'd actually expand on it, other than the fact that as a sub-classification, time dependence of pulmonary elastic behaviour, and if you want, I'll just quickly alter the slide for you. But essentially, the way in which I would do it is that I would just simply say static is comprised of surfactant, recruitment, alveoli, and dynamic would be both above factors plus your stress relaxation and pendulum lift. Can everyone see that now? Yeah, that's sort of how I would, that's because it's going to be, in that last sort of minute and a half, if you can get it out. So I wouldn't be bothered putting too much effort into it unless the question itself was about hysteresis, then you could go into much greater detail. Right, any questions on this? Sorry.
I don't know how does the pendulum affect the dynamic compliance?
Because this describes a redistribution of gas, right? So if you have, this comes into specifically airway resistance, okay?
Yeah.
So, and time constants. But essentially, as your airway resistance increases, all right, your dynamic compliance is going to decrease. Yeah.
All right, so we're just saying, but the pendulum is like movement from fast alveoli to slow alveoli.
Correct. But remember, fast, slow, we're talking about a time constant here. It's compliance times resistance. So if resistance is changing, then so are time constants.
Okay.
Does that make sense?
I'm just like, I'm trying to put it together as to why how that affects the compliance.
Can I ask Rudi just a quick one on that? So are you saying, so for example, if there was less redistribution of gas between alveoli, you would then find that the compliance wouldn't, or the pressure drop wouldn't be as significant for the same volume? Is that where you're saying it affects dynamic compliance?
Yeah, so what I'm saying is, if you have redistribution of gas or pendulum, which occurs in relation to differing time or heterogeneity of time constants of alveolar units, and a time constant for an alveolus is equal to the resistance multiplied by the compliance. If your resistance is changing, therefore the time constant is changing. Does everyone agree with that?
Mm-hmm.
Yeah. And dynamic by definition is something that is changing with time versus static, which is not changing with time. And we know that equilibrium is not occurring due to the fact that there is differences in time constants. This is something that would reduce your dynamic compliance more and more as your, well, normally I'd ask you the question, but as your frequency of respiration increases, as your peak inspiratory flow increases, this would increase, or rather decrease, your dynamic compliance. And this is all in Nuns and Miller's.
Because you wouldn't have enough time for the gas to equilibrate. That's basically what you're saying, is it?
Well, yeah. In simple terms, essentially, what we're talking about is the fact that you're not getting equilibration, and that is a definition of your heterogeneity of your time constants, which is a dynamic issue, because with static, equilibrium has occurred.
Yeah, sweet.
Yeah, I understand that. Thank you.
No worries. And feel free to ask questions. Some of these concepts are explained very poorly in textbooks. Some of the textbooks are wrong. A lot of the diagrams are incorrect. And if you don't understand it, it's a reflection of the educator, not yourself. So just let me know. Right, so then think about this from a Viva perspective, right? I've gone through all of this effort to make this amazing SAQ that I never get asked. And I'm like, well, definitely they're going to ask me about it in the Viva. I was stinging for them to ask me in the SAQ. I was like, oh, God, I'm ready for this question, but it didn't come. So I'm like, all right, well, now I got to deliver it in the Viva. And I was teaching one of the ITs at Western, where I am at the moment. And I was explaining, look, this is how I do it. And then one of the consultants actually said to me, but how would you explain this in a Viva? And then I thought, well, that's a really long-winded way to try to explain compliance in a Viva, and I'd probably waste a lot of time. So you need to manipulate it. And you have the knowledge, so all you do is classify and change things. So you would go and you would define your compliance, but then the way in which you would elicit your determinants would be a more clinical approach. And this is what I sort of came up with, which was anaesthetic, surgical, and patient. And patient is a lot of the factors we talk about in both lung and thoracic CADS compliance from the previous slides. But then you can talk about your anaesthetic factors, your patient positioning, whether you're using PEEP and IPPV, whether they're spont venting, surgical, whether it's a pneumoperitoneum, whether they're doing a thoracic case. These are the sort of like little things you can add in. And when you're talking about Viva presentation, you don't need an exhaustive list. You need to classify so that they can see that you are someone who can structure their thoughts when they're stressed, because that's pretty much the job. And then just give a couple of salient points and wait for them to move on. And if they don't move on, then say a few more points, and eventually you'll say the point that they want to hear. Does that make sense? So this is just information you already know, just changing the structure. And obviously you guys are heading towards the written, so the Viva is not as important for you at the moment, but it's still something to think about. All right, so next we're going to go through, before I hit the slide, we're going to go through work of breathing. So does somebody want to give me their definition of work of breathing?
Pressure times volume, and it's in joules.
Okay, good. We have a start. Pressure times volume, and it's in joules. Okay. All right, so it's work in joules. Pressure, which can be pascals, centimeter of water, usually times distance, but we use volume when we talk about lungs, so we can talk about mils, which is good. All right, so we've got some units. Okay, and that's sort of the equation we'd write down. What about if you were describing it to someone? Is there sort of a sentence you could give, or just if you were explaining it to a lay person, how would you explain it? And anyone.
It's the energy required in respiration, and you can subdivide that into inspiration and expiration.
Good. So you're getting warmer there. Like these are actually really good concepts. All right. So I'll give you a bit of a hand. So the way in which sort of the way that I would talk about this from an SAQ perspective is, it's the energy required to drive air into and out of the lungs in joules, where it's equal to the pressure in pascals or centimeter of water times the volume in mils. Okay. And then if we wanted some extra factors, which we'll go into in the Viva perspective, you talk about, the specifics of that, what it is, its implications from basometabolic rate, its efficiency, these sorts of things. However, in an SAQ, if the question is talk to me, like describe the determinants of work of breathing, you don't have time for a massive introduction. If you can just quickly get out what work of breathing is, I think that's more important, and then move on to the determinants, because that's what the question is about. And the reason I've chosen these SAQs and these topics is that a lot of these topics have diagrams that are incorrect, and they can give you a misleading approach to how to structure this. So yes, so it's the energy required to drive air into and out of the lungs in joules. So pressure times volume, and put some units in there. So normally it's about 2% of our basal metabolic rate, or our VO2, which is about 3 mils per minute. The efficiency is 10%, because most of it is lost as heat and a little bit as noise. And then we have determinants. All right, so determinants are classified as elastic and non-elastic. So I've talked already too much for that part. So does somebody want to talk to me a little bit about the elastic determinants and potentially the percentage contribution they make to total work of breathing?
So the elastic work is what you have to do to overcome the the elasticity of the lung tissue itself, so of the musculature and the chest wall, whereas non-elastic is the air moving in and out of the lungs. And I don't remember what the percentages of each are, but I know that for elastic, it then gets stored as energy. Some is lost as heat, and then some is stored as energy for expiration.
Okay, good. All right. So I'll just, I'll essentially, oh, sorry, no, I'll go on to this. So elastic work is normally quoted as a majority. So depending on text, 50 to 65%. And it has 3 sort of sub-determinants, which are your distension of your lung, or your lung compliance, essentially, your thoracic cage compliance, and then surface tension. And they're sort of the 3 main determinants of your elastic work of breathing, which are normally the largest portion of your work of breathing. And then we talk about non-elastic. And there's also 3 sort of non-elastic factors. So non-elastic is normally quoted as 30 to 55%, if I think that makes, no, that's wrong, 30 to 45%, that makes no sense, of the work of breathing. And the determinants are normally sort of your airway resistance is the main one. So 90% of that, 30 to 45%. And then you have other determinants such as frictional forces, and then this negligible component from inertia. All right. And when you're talking about non-elastic factors and you're talking about the airway resistance, there's both the determinants would be your radius and obviously your flow type as well. Okay. So let's, I'm just going to screen share again, and I just want to go through this diagram because this is another one that people really struggle with. And I think if you just lock it down now, you can sort of manipulate it a bit and add pathologies to it and get a really sort of solid understanding of what's going on with it. So now we're talking about worker breathing. Okay, so I'm not sure what diagrams people use for this, but this is the one that I've come up with and has been approved by Stan the Man. Okay, so essentially, again, we're looking at pressure on our x-axis and volume on our y. I don't really mind what units you use. I was essentially just using intra-pulmonary, but you can use transpulmonary. Honestly, you should probably just use whatever is accurate and quickest to write out. And remember, this is different from a Viva where you're just going to write pressure. You're not going to write specifics. Okay, so if I write intrapleural pressure here, and then I write volume on my y-axis, volume above FRC, all right? So I'm going to start at 0 here. I'm going to start at FRC here. You can already see how bad my writing is. And then we'll just say 500 mils. That's going to be our title volume, okay? And then we're intrapleural pressure 0, halfway mark minus 2.5 centimeters of water, and then full minus 5 centimeters of water, okay? So we all know what we do. We draw our nice little gradient here. Okay, so this is essentially, you know, very similar to our compliance gradient. And what type of compliance are we looking at when we draw this? Does anyone know?
That dynamic?
Yeah, good. Dynamic compliance. Okay, sorry, that's a little bit, that looks more obstructive than it should. So let's pretend that it doesn't look obstructive. Cool. So something like this, apologies for the inspiratory one here. It looks a little bit obstructive and it shouldn't. Should look more like this expiration. So we'll call this inspiration. We'll call this expiration, right? Right. So when we're talking about the fact that the determinants of work of breathing, all right, we have elastic and non-elastic, right? So when we look at this diagram, I don't really know how to enable you guys to sort of mess with this diagram, but where is the elastic portion of my work of breathing here? During inspiration.
Is it the right semi-oval?
So essentially the airway and tissue resistance factors, all right, or the resistance factors or the non-elastic factors, we kind of talk about, which can be subclassified here. So you might not have seen this diagram before, but if you split this one in half, I'll just quickly make this easier. So this is airway and tissue resistance, okay? And this is all your sort of elastic work, right? Of inspiration, okay? And this is what's stored, okay? This is what is stored for your expiration. So that when your expiration occurs here, if it falls within this triangle, then it's passive. And it's only when it goes outside of this stored elastic potential energy, all right, that your expiration becomes active. Does that make sense?
Yeah, I thought, Rudi, maybe I'm wrong. I thought that on the airway, the non-elastic work was all to the right of that center gradient.
Yeah.
So you've written tissue resistance. I'm assuming you mean that's
yeah,
elastic.
You're 100%
work.
right. Yeah, yeah. So this is non-elastic. This is non-elastic.
Okay, all right.
Yeah, yeah. This is elastic. Yeah. Sorry. Yeah. So because airway resistance and tissue resistance are part of the non-elastic factors.
So when you say tissue, I thought that the tissue was elastic.
This refers to, so this refers more to the this refers to your, yeah. So when we're talking about airway resistance, this is talking about your flow type and your airway radius, right? And then when you're talking about tissue resistance, that's that other sort of 10% of your non-elastic resistance. And inertia is just not there because it's kind of not important, right? And then this larger portion, which is replicated or sort of seeing this area here, is your elastic, right? Because this is the majority of work done in the normal patient.
Okay, so if I was just going to clarify it for myself, when you've written that tissue resistance there, you mean the frictional force?
Precisely. And
okay,
this is like an extra point, right? Like, you don't need to do this you don't need to partition this lower part of your curve. You can just write in, non-elastic factors. You don't need to do that. It's just like an extra thing so that you understand it. It's really not required, I don't think, for a pass or even a good score for a question like this.
Thank you.
No worries. All right. So now the things we can do, I probably won't go into them at the moment. We can do a workshop when it comes to Viva time, but what happens to this curve with obstructive pathology, resistive pathology, and how to sort of draw those changes. We can do that more another time, but this is just from an SAQ perspective. That's sort of how I would go ahead and tackle that question. All right, yeah, so I think we already pretty much touched on this, but this was sort of the answer I came up with for what I was going to try and just knock out really quickly if I got Vivaed on this topic. If someone said define work of breathing, this was sort of my definition. I'll send the slides out to you guys. If you use them, they're all referenced from other nuns or millers. No parent can. Which I'm sure Stan will love if he's still there and not drinking wine somewhere. Okay. So the other thing that's kind of complex to explain, well, it is and it isn't, is when we're talking about airway resistance, when we're talking about the non-elastic factors, all right, so that's other 30 to 45% of your work of breathing. The two main determinants are obviously the type of flow and the radius, and they're not independent of one another because we know from Reynolds' equation that essentially, radius changes radius changes velocity and Reynolds number and yada, yada, yada. So how do you explain these things quickly? So when you're trying to get them out in SAQ, you essentially say that when you describe laminar flow, does someone want to describe it for me?
So it's smooth flow and it's faster in the middle, slower on the outside, and it is described by the Hagen-Poiseuille equation.
Yeah, fantastic. So essentially, yeah, it's this beautiful sort of parabolic wavefront.
Parabolic, that's the word.
Concentric cylinders with the central one moving most rapidly, and in some circumstances, the most external actually being static. And when you draw a graph for this, you'll essentially draw an X and Y, and you'll have pressure and you'll have flow and pressure, and you'll have a linear, you basically just draw a line, right? Because the relationship's linear, because it obeys the Hagen-Poiseuille equation when it comes to a change in resistance, or a change in radius. Now, the other thing that they might ask you about, if you haven't heard it already, you probably have during your travels, is that I think someone asked me in the Viva, but at what point does laminar flow occur? And that can be calculated with an equation which calculates your entrance length. Okay, which I won't regurgitate here because it's just excess shit you don't really need to know. And in relation to another question that's commonly asked is, which type of flow is better for purging your anaesthetic circuit, laminar or turbulent? Who knows the answer to that?
So turbulent?
Yeah, great. So turbulent is better for purging and it's better for sampling, right? Because laminar flow is not really truly reflective of a mixture of all components of that gas column. And there are two clinical questions that are kind of irrelevant to us, but they will continually, not irrelevant, but like the sampling one, but they'll continually ask them because I think they just enjoy asking that question. Now on to turbulent, which is kind of the one that's a bit of a pain in the ass to explain. Not so much when you just talk about what it is, but the equations which estimate it. Because if you have a look in nuns, and finish your experimental astrophysics mathematical PhD, you still won't understand the bloody equation in the thing. So these are just some easier ways to explain turbulent flow. So does somebody want to sort of, now that I've explained, now that both myself and Stephanie have had a go at explaining laminar, does someone have a crack at turbulent flow?
Yeah, so turbulent flow is disorganized and displays an eddy pattern of current as opposed to that parabola leading edge that you see for laminar. And then if you were to draw your graph, as you were mentioning before, I think it's a positive exponential shape to the graph or the pattern of flow. And as you said there, if your Reynolds number is greater than 2000, turbulent is more likely.
Yeah, exactly. So the other sort of buzzwords, so it's chaotic, and it is a square wavefront that does consist of eddies, and essentially is more likely to occur as the Reynolds number increases. All right, likely, not 100% going to occur. Okay, so when we talk about trying to calculate it or to explain it mathematically, these are some of this is essentially the summary of the different equations that exist out there. So the driving pressure can be proportional to the flows to the power of 2, can be dependent on density and independent of viscosity. So we're talking more about Reynolds factors there. And then the required driving pressure is proportional to the radius to the power of 5, which is the Fanning equation, which you might have heard of already at some point. And yes, the Reynolds number only predicts turbulence. So don't fall into the trap of when someone asks you, oh, how can you calculate turbulent flow? Don't write out the Reynolds equation and say, this is turbulent flow. Just ensure that you say, well, it predicts turbulent flow, but we don't know with absolute certainty you will have turbulent flow. Obviously, this is what you're going to draw if you're drawing laminar, and this is what you're going to draw if you're drawing turbulent. Okay, pretty easy. One's linear, one's a runaway curve.